Okay, it's 2:45. So we'll get the session started. Welcome everyone to our session, Preeclampsia, What's Old and New. Preeclampsia is obviously a really important perinatal complication for those of us who do OB anesthesia, and we have five really excellent presenters here today. So Andrea Ibarra, who's at UPMC, but soon to be at Stanford, uh, is going to present on the pathophysiology of preeclampsia. Then Jennifer Banyan is going to talk about cardiac complications of preeclampsia. She's a professor at Northwestern. Then Melissa Bauer from Duke is going to present on the anesthetic management of severe preeclampsia. And then finally, and Andy Trainer, also from Stanford, is going to present on post-delivery preeclampsia. So look forward to everyone's talks, and hopefully we'll have a few minutes at the end for discussions. I think we'll do all of the questions at the end. Okay.
Hi. Oh, I'm loving this stepping stool. Hi, my name is Andrea Ibarra, and I was at UPNC, but I'm transitioning to Stanford starting November 1st. So the title of my presentation is Pathophysiology of Preeclampsia. Let's see if it moves. I might have to, sorry. There, I have no conflicts of interest. And so let's start by looking at these pictures. Majority of these women, you probably have seen them on TV, but what they share in common is that they almost die during pregnancy because all of them develop hypertensive disorders of pregnancy, specifically preeclampsia. And so that has captivated the eye of researchers. Why these women are developing preeclampsia, even when they are healthy, even when they are physically active, and even when they have the best health care that a person can possibly have. And for that reason, there has been a lot of research in this area. So let's start by defining what preeclampsia is. So all of us know that it's a type of hypertensive disorder of pregnancy. By the most recent guidelines given by ACOG, we know that preeclampsia, it's defined as a new onset of high blood pressure with a systolic higher or equal to 140 and a diastolic higher or equal to 90, in the presence of proteinuria and/or organ damage findings. Usually it's diagnosed at 20 weeks of gestational age. Unfortunately, in the US, 1 in 25 pregnancies suffer from preeclampsia. But more importantly, now we know that even with the delivery of the placenta, the effect of preeclampsia does not end there, and it has long-lasting effect in the life of a woman. For that reason, there's a lot of studies trying to figure out who are these people who are going to develop preeclampsia. And so over 75 RCTs have already reported that low-dose aspirin is safe and effective in preventing preeclampsia. But more importantly, and the most challenging question of this therapy is who are the people at the highest risk that will benefit the most from this particular therapy? And so a very recent systematic review meta-analysis looked at the clinical risk factors that can put a woman at risk of preeclampsia. And so they reported that prior preeclampsia and chronic hypertension have an increased risk of 8.4 and 5.1 fold. However, although this gives you an insight of who's going to develop preeclampsia, it doesn't necessarily establish causality. But so why these women indeed develop preeclampsia, the real mechanism and their underlying pathway is still unknown. There are several hypotheses that have been postulated saying that women develop preeclampsia because they have sleep disorders, because they have endocrine disorders, even because they develop COVID-19. But the most accepted mechanism has been the uroplacenta ischemia. And so when we think about this particular mechanism, this emerging mechanism, we have to think about this two-stage model. In the first stage, during the first trimester of pregnancy, we have this abnormal placentation. And in the second and third trimester, we have this maternal syndrome that results from all these placenta factors that get released to the maternal circulation. Ultimately, this results in systemic endothelial dysfunction. And so when we talk about abnormal placentation, we have to understand what happens in normal pregnancy. So in normal pregnancy, the trophoblast invades the spiral arteries and transforms them into bigger caliber arteries with lower resistance. And you want that because you want to nurture the fetus. But in preeclampsia, unfortunately, you have defective trophoblast of invasion of spiral arteries. You have failure of vascular remodeling and ultimately inadequate uroplacenta blood flow. And all these triggers release of anti-angiogenic factors, inflammatory mediators, and placenta debris into the maternal circulation. And so when we talk about the release of placenta factors, we're going to talk about specifically of one particular biomarker that has been extensively studied for more than a decade. This is SFLT1 protein that has been found in higher concentrations in placentas of preeclamptic women and even in the serum. And so this particular protein binds and antagonizes BEGF, PIGF, and so prevents the interaction with their endothelial receptor. And so BEGF and PIGF are potent endothelial cell mitogens that regulate blood vessel development and homeostasis. And so you get this in preeclampsia, this imbalance of angiogenic imbalance, and as a result, you get generalized endothelial dysfunction. More importantly, there is a synergistic effect with the soluble endoglobin, which is also increased, that causes and induces an overall anti-angiogenic state in preeclampsia. And so the key discovery here has been that there's an imbalance between pro and anti-angiogenic factors and this is the central pathophysiology of preeclampsia. And so it is interesting because in the last couple years, the FDA approved a particular laboratory that can help clinicians identify or predict the likelihood of developing severe preeclampsia within the next 2 weeks. But it's very important to highlight here that the challenge still remains during the first trimester, and even before the woman is pregnant, we still don't have biomarkers and laboratories that can tell us this particular woman is going to develop severe features or is going to develop preeclampsia. But nevertheless, this is an important breakthrough in clinical practice because this has the potential of reducing iatrogenic preterm deliveries, potentially reducing resource utilization without increasing the risk of having adverse maternal and neonatal outcomes. Because at the end of the day, it's more important than identifying or defining or labeling somebody with preeclampsia. It's more important to actually reduce the risk of developing adverse maternal and neonatal outcomes. Now, switching gears, there's another pathway or another mechanism that has been postulated when we talk about why women get preeclampsia, and this has to do with a pro-inflammatory state. So in normal pregnancy, you have T cell shifting to an anti-inflammatory Th2. In preeclampsia particularly, you have increase of Th1, which releases pro-inflammatory cytokines. Additionally, researchers have reported elevated complement levels and some genetic mutations in C3. And so preeclampsia may represent an immune-mediated disorder with placental involvement. And so we have already talked about this two-stage model. And so now I'm going to focus into what it means to have systemic endothelial dysfunction. And so there is growing evidence that, like I said at the beginning of my presentation, that preeclampsia doesn't end with the delivery of the placenta, right? So studies have shown that people who have history of preeclampsia, later in life, they have an increased risk of developing hypertension, cardiovascular disease, end-stage renal disease. They are more likely to have a stroke and die from cardiovascular events. I am particularly interested in the effect of preeclampsia in the brain, and that's where my research is focused on. And so in a very small study during the peripartum period, we reported that women with preeclampsia compared to normotensive had changes in cognition. And when we looked at the proteomic profile of the preeclamptic women compared to the normotensive women, we observed that there was an increase in fibrinogen levels in the preeclamptic women, When we took all these proteins that were different and put it in pathway, in cluster pathway analysis, we saw that these proteins had a role in complement activation, which for me was very captivating, because now we know that there's a pro-inflammatory state in preeclampsia, and perhaps, and this is a hypothesis that we're proposing, that the changes in the brain due to preeclampsia might have an underlying neuroinflammatory mechanism. Additionally, we use the retina because embryologically it shares the same characteristics with the brain to see and to correlate what we're seeing early on during the peripartum period. So in this particular study, we recruited women who delivered 10 to 15 years from the time of the study visit to do retina imaging. And what we observed is that the retina of the people with history of preeclampsia compared to those who didn't have it or were normotensive controls was thinner. And this is very important because, number one, it tells us that there is like regional differences in the retina, perhaps saying that there's a vascular compromise in the preeclamptic women. But the second thing is that in the Alzheimer's framework, it has been already established that those with thinner retina and who have Alzheimer's, that thinner retina correlates with changes in the brain and also correlates with cognitive decline picked up by neurocognitive testing. But obviously more research needs to be done to establish this connection, to actually reveal what the underlying pathway of the effect of preeclampsia in the brain. And so these are the key take-home messages. Preeclampsia is a complex multi-organ system with placenta origins. The abnormal placentation leads to angiogenic imbalance and endothelial dysfunction. Preeclampsia, it is a marker of cardiovascular and cerebrovascular disease. And obviously more studies are needed to evaluate these long-term effects of preeclampsia, specifically in the brain. Thank you so much, and I will take questions at the end.
Hello, my name is Jennifer Benayan. I am an associate professor of anesthesia at Northwestern, and today I was asked to talk about cardiac complications of preeclampsia. My disclosures, I'm the editor of the APSF newsletter. So we just heard a little bit about the pathophysiology of preeclampsia, and the key is that preeclampsia fundamentally alters maternal cardiac physiology. Preeclampsia is not simply high blood pressure pregnancy. It's really a cardiac disease with structural and functional consequences. And so most of you likely have seen this figure before. It's a classic representation of the hemodynamic changes that occur throughout pregnancy. And during pregnancy, we see an increase in cardiac output, as seen here in navy, that increase in stroke volume, as seen here in orange, and a decrease in SVR, as seen in green. And these shifts are essential to support the fetus, as we know, ensuring adequate uteroplacental perfusion, oxygen delivery. But this also really means that the heart during pregnancy is working harder than it would at a non-pregnant baseline, and therefore it has less ability to further increase the output when stressed. During labor, delivery, and in the medium postpartum period, rapid fluid shifts occur, as we know, and a healthy pregnant woman, they compensate. But a woman with preeclampsia, these stresses can really tip the balance into cardiac complications. So in preeclampsia, vascular resistance is elevated. Unlike the drop in SVR that we normally see during pregnancy, plasma volume expansion is limited. So preload is often inadequate despite having this volume overload in the interstitial space. And the left ventricle becomes stiff with diastolic dysfunction. It cannot relax well to accommodate filling. And so that's why even small fluid shifts or an increase in blood pressure can tip these patients into pulmonary edema. Preeclampsia just literally is a stress test that a mother's heart may fail. And so here are some of the echo changes that we see in preeclampsia. Alicia Dennis and her colleagues published a series of studies using TTE in women with severe preeclampsia. And they found that systolic function is typically preserved. Most preeclamptic women have a normal ejection fraction. And their left ventricle is not dilated, but it's thicker. There's increased LV mass, there's concentric remodeling, and there's evidence of hypertrophy. But the key abnormality here is diastolic dysfunction. So we see reduced relaxation, that increase to E to E prime ratio, abnormal E to A patterns. These echo patterns confirm what we've already discussed pathophysiologically. Preeclampsia creates a heart that pumps adequately, but it relaxes poorly. And so these echo findings translate directly into those complications that we're now going to see in labor and delivery. So pulmonary edema, ischemia, arrhythmias, and even peripartum cardiomyopathy. And we're going to go through each one of those now. So severe hypertension is really the hallmark that we all know about preeclampsia, and that's really what drives this cardiac risk to the heart. High SVR means that the left ventricle is pumping against a much higher afterload than normal. And so over time, and particularly in those patients with severe preeclampsia, this can cause diastolic dysfunction. The heart becomes stiff and doesn't relax properly. But what's tricky about these patients is that they look pretty good when we meet them. Their EF is, again, most likely preserved. They don't have obvious symptoms, but that changes, right? You give them a fluid bolus, you start your neuroxy anesthesia, maybe you counter some stress of labor and surgery, and then they can really go poorly. So managing patients with diastolic dysfunction in labor and delivery requires some careful planning. And so here's a few practical points. Number one, we want to treat severe hypertension promptly. A systolic over 160 in a preeclamptic patient is very concerning. In fact, in one case series of 24 women with preeclampsia who had a hemorrhagic stroke, 23 of them had a systolic blood pressure above 160. So that's a number that makes you nervous. Number two, cautious fluid management is key. Patients, again, they're diastolic dysfunction, so even a little bit of fluid can cause a problem in these patients. They have a stiff ventricle. Three, we need to be careful with our neuroxy anesthesia. We want to titrate slowly. We don't want a big drop in SVR right away. Hypotension precipitates pulmonary edema and it can compromise the fetal perfusion. And four, we want to anticipate labile blood pressure. Whether it's during induction or surgical stimulation, you want to have both your vasopressors and your antihypertensives ready. So these women, again, they look clinically stable at baseline, but small hemodynamic changes can really tip them over. So next is pulmonary edema. It occurs in about 3 to 5% of patients with severe preeclampsia. And again, unlike classic heart failure, it's not just about fluid overload. This is a combination of capillary leak, impaired relaxation of the LV, and dramatic postpartum fluid shifts. So again, a normal fluid bolus is going to overwhelm the system. And really this can appear very abruptly. All of a sudden the patient's dyspneic, hypoxemic, rails. And here's the key. Any patient on labor and delivery on oxygen, especially with preeclampsia, should raise concern. You should be nervous about those patients. It is not normal. Needing oxygen in this setting should make you go to the bedside and evaluate the patient. So again, management goals when it comes to pulmonary edema, give fluid with extreme caution. Remember, you can always give more if necessary, and be ready to manage acute pulmonary edema with oxygen and diuretics promptly. Pulmonary embolism is another possible cardiac complication of preeclampsia. Remember, pregnant patients are already in their hypercoagulable state, and then preeclampsia further increases that risk because of endothelial dysfunction and inflammation. And clinically, this can be challenging. PE could look a lot like a pulmonary edema or heart failure. Shortness of breath, hypoxemia, tachycardia, they can be very tricky to distinguish at the bedside. So pleuritic chest pain and persistent tachycardia can be helpful, but still very vague symptoms. So if you suspect PE, we recommend a bedside POCUS exam to look for right heart strain. Sometimes that's possible. If your clinical suspicion really is high, you could get a CT pulmonary angiogram for confirmation, and then management is anticoagulation. Another major but often under-recognized complication is myocardial ischemia. I know these women are young and they should be healthy and they don't have coronary disease, but that doesn't mean that they're not at risk for ischemia. Preeclampsia creates this perfect storm for ischemia. So coronary vasospasm, endothelial dysfunction, microvascular injury, they all cause problems to impair perfusion despite these normal coronary arteries. And then these hypertensive surges can increase the myocardial oxygen demand, and that diastolic dysfunction limits your coronary filling. So patients can suddenly have chest pain, EKG changes, or unexplained hemodynamic instability. And for us, the take-home message is we want to minimize ischemic triggers when possible. So we're going to be blunting that sympathetic response to laryngoscopy in these patients. We want to control their blood pressure. Even though we know we're about to drop their blood pressure, we want to be mindful of that as we're about to stimulate them. And we want to remember that a healthy woman who's 35 can still have an ischemic event, and not to forget that. Another complication we see is arrhythmias. And they can be triggered both by the disease and actually by our treatments. So arrhythmias and preeclampsia are less about structural heart disease and much more about stress on the myocardium. So this could be provoked by electrolyte shifts that we see around delivery. Hypertension, LV strain, ischemia can all predispose these patients to rhythm disturbances. So magnesium, while protective against seizures, alters conduction. It could prolong our PR interval, it widens the QRS, and even really high levels of, hopefully we won't see, but can cause heart block or asystole. And then conversely, these patients that were diuresing, they get low magnesium, they get low potassium. That also can trigger arrhythmias. So clinically, we need to be watching these patients. If you're worried about them, they should monitor their EKGs. We want to all be aware, remember the magnesium effects. We want to anticipate arrhythmias, especially in patients who are on antihypertensive, diuretics, or magnesium. And remember, if arrhythmia is unstable, electrical cardioversion is indicated and is safe in pregnancy. Should be doing that as necessary. Finally, I just want to do a few slides on peripartum cardiomyopathy, or PPCM. This is really a distinct entity that overlaps with preeclampsia. PPCM is classically defined as new onset heart failure during pregnancy or postpartum with no other obvious causes. It is not just a severe version of preeclampsia, which is sometimes said in lectures and in different books. But really, I think that's because preeclampsia is such a strong risk factor for PPCM. But to keep in mind, we talked about preeclampsia causes diastolic dysfunction. It has a preserved ejection fraction typically. But here in PPCM, they're having systolic cardiomyopathy. They have a depressed ejection fraction. So they're two entities. But remember, a patient with PPCM can decompensate very rapidly under anesthesia. Even routine fluid administration or reduction of anesthesia can really precipitate cardiovascular collapse. And management is going to be very similar to our other dilated cardiomyopathies. We're doing our afterload reduction. We're doing some diuretics. We're giving our inotropes if necessary. But remember, ACE inhibitors should be avoided in pregnant patients. Now, PPCM is really often missed because symptoms overlap with normal postpartum recovery. Delayed recognition increases your risk of severe complications. So if you have a patient with preeclampsia and they have persistent or worsening symptoms, and you're seeing some shortness of breath and edema, some hypotension, really bad fatigue, you want to at least think about PPCM and get an echo to look for that. So we've talked a lot about the acute cardiac complications that can make preeclampsia so dangerous during pregnancy and delivery, but what's equally important and often overlooked, although it was already mentioned, is that preeclampsia doesn't end at delivery. It's an early warning sign for future cardiovascular disease. Study shows that those with a history of preeclampsia have a 2 to 4-fold increased risk of chronic hypertension, ischemic heart disease, and stroke later in life. And pathophysiologically, preeclampsia leaves behind lasting endothelial and microvascular injury. These women essentially experience a cardiovascular stress test during pregnancy that unmasks an underlying vulnerability. And because of this, both ACOG and AHA now classify preeclampsia as a major cardiovascular risk factor on par with diabetes or smoking. And so we need to be counseling these patients about their long-term risk. We want to ensure that they have ongoing follow-up with primary care cardiology. We want to emphasize preventive strategies such as blood pressure control, lipid screening, and really lifestyle optimization. To wrap up, the key takeaway here is that preeclampsia is fundamentally a cardiac disease. It's not just elevated blood pressure. It alters our preload, our afterload, and our myocardial function. And our role here is to recognize these changes early, individualize anesthetic management, and anticipate hemodynamic instability. Preeclampsia predicts long-term cardiovascular morbidity and mortality. And by recognizing that connection, we can help these women not just have healthier pregnancies, but really live healthier lives beyond it. Thank you.
Hi everyone, I'm Melissa Bauer. I'll be talking about the anesthetic management in severe preeclampsia. Okay. So first I'm going to talk about the blood pressure management and metrics for that, as well as clinical pearls for anesthetic management for neuraxial and general anesthesia. So starting with blood pressure treatment, the standard of care and the recommendation by the American College of Obstetricians and Gynecologists is that we treat blood pressure within 1 hour when it's severe. And so that is with being sustained for 15 minutes or upon the recheck that person still has a blood pressure of a systolic greater than or equal to 160 and or diastolic blood pressure greater than or equal to 110. And then also at the time of diagnosis is what it says. There's no specified metric, but it says at the time of diagnosis that person should have a magnesium infusion to reduce the risk of having an eclamptic seizure. So a couple of things for your anesthetic management is that there is no exception for that because the person's going to have an anesthetic. So we don't want to be holding up the treatment because we're getting ready to have an anesthetic. There's a lot of things that you can do to counteract the potential hypotension. And then also with magnesium, American College of Obstetricians and Gynecologists also recommends to not shut off the magnesium infusion when getting ready for the OR. The reason for that is that there's a very long half-life and it's going to take a long time for that to come out of the tissues, and it's not going to improve your atony, but what it will do is lower the blood levels of magnesium and increase that person's risk of having an eclamptic seizure. So we want to, for anesthetic management, we're going to treat the blood pressure and continue the magnesium infusion. So I want to talk so much again about that study that she mentioned with the patients that had the stroke, because I think that it's a really important study to look into the details of it. So this was done a while ago, but this is kind of one of the landmark studies on preeclampsia. This was 28 patients who had a hemorrhagic stroke, all due to hypertension. Only 3 of them received any treatment pre-stroke. Over 50% of them died, and only 3 made it out with without any deficits. But this is probably one of the most important pieces of the study, is taking a look at this here. In the patients prior to stroke, this was their systolic blood pressure range. It was 159 to 198. And 95.8% of them had a pressure greater than 160, but actually it was only 1 out of the 24 that had it less, and it was 159. So it's probably a measurement error. It probably was greater than 160. But anyway, the issue is that treating that blood pressure is critical. We know that greater than 160 highly increases their chance of having a hemorrhagic stroke. It's very different than the general population where you can accept much higher pressure. So we want to make sure that we're treating that appropriately. All right, so as far as neuraxial analgesia or anesthesia, obviously an early epidural placement is preferred, but what about the platelet count and how often do we need to check that? All right, so let's go through a couple of things because I think this is really helpful. There was a study that was done a couple of years ago that looked at 984 women with preeclampsia. And they looked at, this is retrospective, they looked at their platelet counts up to 72 hours prior to delivery, and only 1% of them had a platelet count greater than 100,000 initially, that subsequently dropped to less than 100,000. So I know we get very concerned and want to keep rechecking that platelet count to see that it's dropping, but that's actually a pretty rare thing to occur. And if you take a look at this data, this is the graph that they had done to show the patients, the 11 patients that this happened to. And if you look at this graph here, you'll see this. Those were the 2. So they started at a normal platelet count, and then they dropped subsequently less than the 70,000 that would be inconsistent with the guidelines, and I'll show you with that. One dropped to 56,000, one dropped to 69,000, but they both had help. They didn't just have preeclampsia with severe features, and I think that that's pretty important here. So what do the guidelines say? So this is the SOAP Interdisciplinary Consensus Statement on Neuraxial Procedures in Obstetric Patients with Thrombocytopenia. And this was endorsed by ACOG, Society for Maternal Fetal Medicine, of course, SOAP, ASRA. And this was supported by the American Society of Hematology, not because they disagreed with anything, it's just they had a policy that they would not endorse anything they didn't write themselves. So just so you know why it says supported and not endorsed. But taking a look at this algorithm, we're going to go through this specifically for preeclampsia because I hear a lot of times people say, well, I don't know if I can do neuraxial. We don't have the labs back yet. It was checked yesterday. There's a lot of things to think about here. So let's go through this. So first, you're always going to take your clinical history concerning for bleeding. So their bleeding history, which that's in the paper that was created by a number of bleeding history assessments that are done by hematologists, and there's a table in there that you can see how to do that. We don't have time to discuss that right now. But you'll take a look. If they have a bleeding history, then that's concerning, you would skip that, and any current signs of coagulopathy. So whatever their platelet count is, if that's concerning because they're showing signs of coagulopathy, then obviously you would want to avoid neuraxial. But if that's negative, then you're going to move to the etiology of thrombocytopenia. And so if it's hypertensive disorders of pregnancy, that would mean that they had a normal platelet count in the past and that their platelet count is consistent with their diagnosis of preeclampsia with severe features. But then look clearly here. We say on here consistent with HELP syndrome, and that's really key. We were very intentional about putting that in here because there aren't a lot of data to suggest that you need to keep checking that platelet count every couple of hours to make sure that it's not dropping just because the patient has pre-E with severe features. It's more if they have a clinical presentation and concern for having HELP. So if you've had a platelet count that was somewhat recent, you don't need to have to go to sleep just because you didn't have time to send labs and now they want to move forward with delivery for some reason or another. So I just want to make that clear because there aren't strong data to say that you really need to check that every 4 to 6 hours. But you should if they have HELP or something or a presentation consistent with that. Then you'll move to, is the platelet count greater than or equal to 70? There have been a lot of data to show that if that's the case, it's very low risk and you can go ahead and proceed. Given that you've gone through the rest of the algorithm, you have a known etiology because we're talking about preeclampsia here. And then if it's less than 70,000, then you can take a look at the risk and benefits, and then you can decide to move forward with neuraxial. So just to share with you this here, because we hear a lot of that I didn't have time to check labs or I'm really concerned. I think that it's really important to take a look at the algorithm and go ahead and follow that through and reassure yourself that it's a pretty rare phenomenon for someone to have a normal platelet count and then all of a sudden that it's less than 100 or less than 70. So moving on to general anesthesia, I just want to share with you here that the biggest thing that we want to do with general anesthesia is blunting the adrenergic response to intubation, but also there's going to be some labile blood pressure, so you need to be prepared with both medications to bring up the pressure and reduce that pressure. This paper is somewhat old, but I think it's a classic, very good paper. And actually, if somebody's looking for a new project, I think you could do another literature search and put together anything that has come out since then. But this is a really nice paper that goes through all of the different ways that you can reduce the adrenergic response to intubation. And so it goes through all the opioids, it goes through induction agents. Surprisingly, back then, there wasn't any data on propofol. They just had thiopental in this paper. So a lot has changed since then, but they go through the induction agents. They also go through lidocaine, opioids, a number of different ways to reduce blood pressure. So labetalol, esmolol, nifedipine, a number of different ways that you can do that. And so I just suggest that you read this paper and you decide for yourself based on the evidence which medications that you'd like to use to improve the hypertensive response to intubation and also keep their blood pressure stable throughout. And if anyone's looking for a new project, consider doing that one. But with that, thank you so much. And I'm going to turn this over to Dr. Trainer.
Okay, so last but not least, I'm Andy Trainer. I am a clinical professor at Stanford. I'm an obstetric anesthesiologist. I also work in the main OR and various offsites. I am so happy to be here, and I really appreciate the other panelists and Dr. Bateman for having me. And I hope that I can there we go. Okay, so we've already discussed this. Preeclampsia is a multi-system disease. It affects about 3 to 8% of pregnancies, and it's a leading cause of maternal morbidity. And I remember, growing up, hearing about someone in my family who had died from toxemia of pregnancy, and that's preeclampsia. And the reason that I bring that up is because that old term, to me, helps me conceptualize that this is a systemic disease. This affects every system in the body. And so I think that helps us understand the pathophysiology and also the long-term effects. So we've talked a little bit about some of the symptoms here. We're talking about headaches, sometimes severe, which we're going to get to in detail later, vision changes, abdominal pain, swelling, shortness of breath, nausea and vomiting, and rapid weight gain. All right, well, but delivery is the cure, right? How many people in medical school or whatever in your training did you learn, well, the cure to preeclampsia is to deliver, right? I did. Okay, well, actually, it's not quite that simple. And so I'm here to talk a little bit about that piece. So about 5 to 6% of preeclampsia cases present postpartum. And it's actually one of the leading indications for postpartum readmission, and it can develop after a pregnancy with or without antecedent preeclampsia or other kind of hypertensive disease of pregnancy. And these patients are at really high risk for adverse outcomes, which was why we thought that this was an important thing to discuss here in this forum. These patients have seizures, pulmonary edema, stroke, and actually about 40% of eclampsia seizures occur postpartum. Okay, so we heard that the placenta plays a key role in this, right? So if you're like me, I went down some rabbit holes going, wait a minute, but the placenta's out. So then what's going on? Why? And I can't wait to pick your brain, like have some coffee and talk about all these things because it's fascinating, right? To me, it's fascinating. Placenta's gone, but yet this disease is still there. So what happens? And I don't profess to be an expert on this, but there's a couple of very interesting genomic and epigenetic studies looking at gene methylation pathways, and they've found that there are unique pathways for just specifically postpartum preeclampsia and what they call classic preeclampsia, which kind of reminds me of like classic Coke. But anyway, so the common pathways, there's some that are unique to the development of preeclampsia after delivery. Okay, well, what does that have to do with us? Usually, the patients deliver, they go home. Why are we talking about this at an anesthesia conference? What does that have to do with us? Well, this information is for all of us, and here's why. So hospitals that have a lower delivery volume, they actually have a higher rate of severe maternal morbidity when patients are admitted postpartum due to preeclampsia with severe features. And the most common thing that is seen is heart failure, thank you, and pulmonary edema. And you've probably seen this graph or this chart, and if you haven't, this is from the most recent iteration of the obstetric anesthesia workforce survey, which is showing that as the number of total births has essentially stayed the same since 1981, but the number of hospitals that are delivering obstetric care in the United States has gone down dramatically, and even more so since 2020, which leaves us with maternal care deserts. And the reason that matters for this talk is because the less maternal care you're seeing, the more likely that when these patients show up in the ED or they call you for this, that they're not going to be thinking about this. And the paper that presented some of this information was talking about, well, consider risk-reducing initiatives to optimize postpartum care at these types of facilities. And I would offer to you that just sitting in this room is a risk-reducing initiative. And I'll get into why. Because if you are thinking of this, you're going to be able to be proactive about taking care of these patients. So missing postpartum preeclampsia has consequences. And this is one case report. The postpartum preeclampsia world doesn't have lots and lots of studies. They have a lot of case reports and hypotheses. But this is a case report essentially of a woman who had an uncomplicated delivery with epidural analgesia, and then for 3 days went to the ED with a headache and leg pain and upper abdominal pain. Each time her blood pressure was far in excess of that dangerous level of in 160s, in the 180s. She got discharged home every time, and on postpartum day 8, she had a persistent headache, couldn't get her blood pressure at home, and then at that point became unresponsive with emesis. She had a PEA arrest. She was a difficult intubation, so we could be called for that. And she ended up on ECMO and having to get transferred to a higher level of care. She recovered after 72 hours of ECMO and critical care, but has ongoing panic and PTSD that's going to live with her for the rest of her life. Dr. Buckland, who was one of the proponents of making sure that we talked about this, sent me this case, which was a 35-year-old that was 7 days postpartum, presented to the ED with a headache. And the ED called the anesthesia service about a headache. They thought, oh, this is a post-dural puncture headache. And because Dr. Buckland had gone to a presentation about postpartum preeclampsia like a month earlier, she thought, you know what, let's make sure that we know the patient's blood pressure and realized that this was most likely postpartum preeclampsia, called OB. The patient had a seizure in the elevator prior to reaching labor and delivery, but she was treated and made a full recovery. I'm also a survivor of postpartum preeclampsia. I was lucky enough to go into my OB saying, oh, I feel awful. And then have it diagnosed by clonus and elevated blood pressure and got to get admitted to the hospital and made a full recovery, and here to tell you the story about it. So what are we most likely to get called about? We are most likely to get called this phone call. Can you come and see my patient? She has a headache. Okay, that's what, and they're going to be thinking, oh, it must be from your epidural or your spinal. But I offer to you that anytime we get called for a postpartum headache, this is our real opportunity to go in and really be doctors and to really look at the full picture and the patient and really think about the differential diagnosis. So my really wonderful esteemed colleague, Dr. Jessie Ansari, proposed this mnemonic for postpartum headache, which I love. And it's preeclampsia. It spells partum. So if you think about that, preeclampsia, anesthetic, reversible causes, thrombosis, use your brain, which would be things like caffeine withdrawal, musculoskeletal, things like tumors, and then migraines or meningitis. So how do you differentiate between postpartum preeclampsia and a post-dural puncture headache? I've set up a little cheat sheet here for us. So both of these types of headaches are throbbing and they have visual disturbances. Post-dural puncture headache tends to have photophobia as the most common visual disturbance, but it also can have double vision. Preeclampsia has kind of blurry vision or feeling like they're seeing spots. The nature of the headache is a little bit different with preeclampsia than with post-dural puncture headache. It tends to be more whole head versus frontal or neck pain. The blood pressure is usually normal with post-dural puncture headache, and it's usually elevated with preeclampsia. The positional headache is usually a post-dural puncture headache. It gets better when the patient lies down, and it gets worse when the patient stands, and that has to do with intracranial hypotension. And preeclampsia headaches tend to not be positional, or they get worse when the patient lies down. Again, another nice mnemonic, when you should order imaging in a patient that has a postpartum headache. And this one is scan me, but anytime the headache is sudden or severe or there's a seizure involved, anytime that the patient gets worse when they're supine, altered mental status, neurologic deficits, medications without relief, and I will offer that an epidural blood patch without relief, that's somebody that you may want to think about, or significantly elevated blood pressure. Now, the obvious thing is that you may not see abnormalities in preeclampsia, but you may see some cerebral edema, things like that. Okay, so the key points are that postpartum preeclampsia happens. Morbidity and possibly the mortality rate is higher with postpartum preeclampsia, and it's even higher in centers with low delivery volume. Always consider postpartum preeclampsia as part of your differential for a postpartum headache, and that not every postpartum headache is due to neuraxial anesthesia, and this is where we really need to be thinking about the full differential. So thank you so much to all my co-panelists and Dr. Bateman and Dr. Brenda Buckland. And this is my plug for the SOAP annual meeting in Montreal, Canada this year.
Well, thank you so much, Andrea, Jen, Melissa, and Andy for really excellent talks. We have about 15 minutes, and we're happy to take your questions. The purpose of the session is to really help you provide care for the patients that you take care of on your labor delivery units. So feel free to ask questions about things that were covered in the presentations or other questions you have related to the care of preeclamptic patients. And if I could ask you, when you have a question, to come to the microphone and introduce yourself and where you're from.
Hello, Ned Nasser from Advocate in Chicago. Thank you all very much for excellent talk. Quick question for you. You mentioned, slow epidural, so forth for these patients. What are your thoughts on combined spinal epidural, low dose? I mean, I know that's all you do at Northwestern, but that's pretty much what I do. But what are your thoughts on that? So, should we just do slow titrating epidural on all these patients, or can we? What's the data and that's that? Thanks.
I mean, I think I'll let everyone else also answer, but I think it depends. So I do a lot of combined spine epidurals at Northwestern, correct? But we also do a lot of DPE. So where we put the needle through this into intrathecal space, but not necessarily give a medication to drop our SVR. You also can decrease the dose if you want to do a CSE. Or yes, if I'm worried about their lability, I will stay in the room and just do an epidural and just kind of take my time. Obviously, clinically it's busy. It depends on how the patient looks. But yeah, I mean, I think giving this patient a full liter bolus and then going in and doing their biggest, giving a big combined spine epidural gets them into trouble, right? So I do think that avoiding that, obviously not everyone is going to do poorly. Most patients do well, which is why that small amount of people get us into trouble. Most patients are okay, but it's that individual who really is labile that can get you into trouble. So I would recommend slow dosing. I don't know if anyone else.
I think yeah, go ahead.
Yeah. I think the biggest thing is to be prepared with everything. So even if I'm in the OR and I do a CSE for a C-section, I make sure that I have that cuff on every 1 minute. And then I also have my phenylephrine actually in line, which some people are like, why are we hooking that? Because you'll need it. And so you want to start treating when you see a drop in the pressure, not when it's really low. So like if they're starting at 160 and then now you're at 140, I would turn it on a low dose and I would get that going, because what you want to do is preemptively make it stable for those patients rather than waiting. And now it's 130, then the next one's going to be like 70. So, but open to whatever else does.
I do similar things, and I hearken back to what I learned when I did neuroanesthesia, and I was learning about cerebrovasal autoregulation and trying to keep the blood pressure sort of near their baseline. I mean, I don't want to keep it at like 160 over 110, but also recognizing that like this isn't a patient that necessarily needs a blood pressure of 100 over 60, because what I notice is that when those patients start to drop, that the babies really start to drop, and we start to see fetal bradycardias, and it's likely due to the placental the abnormalities of the placental vasculature and the uteroplacental insufficiency that we see. So I think treating early and keeping them at maybe the high normal range is probably a better place to be.
Yeah, I agree with the comments. One thing I might just add, 30 years ago, 25, 30 years ago, it was very controversial within OB anesthesia about whether you could do spinals in patients that had preeclampsia with severe features. And there were some nice RCTs that were actually done in the 1990s where patients with severe preeclampsia were randomized to either epidural or spinal anesthesia for C-section. And both maternal and neonatal outcomes were not different between the two groups. The historic concern had been that with the sympathectomy, that with the spinal, that you'd get really profound hypotension in patients that were relatively intravascularly volume depleted, and the RCTs that were done didn't really bear that out. The patients that got spinals required a little bit more pressure, but not a lot more than the epidurals. And so I think the practice in general is to do spinals if there's not a reason to otherwise do an epidural. There may be patients that are really tenuous from a cardiovascular standpoint, or where the placental perfusion is really compromised, where you see reverse diastolic flow on the ultrasound, where you'd want to contemplate doing something that was had a little bit of a slower onset, but I think in many circumstances you can use spinals. Yeah, please.
Hi. With the patient who is already hypertensive and it's controlled, and would you recommend to do like a routine echocardiography, like diagnostic echocardiography, when they are approaching to the delivery time?
So the question is, in a patient that has a hypertensive disorder of pregnancy, is that in and of itself an indication for doing a cardiac
like controlled
echo?
Yes, but I don't know, like noticing the whole changes with pregnancy and cardiovascular changes. Would you recommend to do a routine, like to prevent or be preparing in case of, I don't know, developing eclampsia or something?
Sure. So absent like any other symptoms of heart failure, would you do a routine echo in this population?
So there's actually been a really big push to figure out like who should be, like, we know we're missing diagnosis with peripartum cardiomyopathy, for example. Who should get routine echoes? Like, who should we be doing this for? Like, what's the trigger? And so one of my examples was like, if they're on oxygen, I think that's a really good example of someone who should be getting a POCUS or calling. Who do you call cardiology in the middle of the night? If they're on oxygen and they're preeclamptic, I would call for that. The other people, it's hard. It's how much access do you have to POCUS? If it's easy for you, sure. If it's easy to get a POCUS exam, the more you do, the better. I would say do everyone. The question is, who are you calling cardiology in the middle of the night for? And I think that's a much harder trigger. I don't think I would call cardiology in the middle of the night for all my preeclamptics. I don't know if people feel differently. But I think if they are really labile, if you think that they're on oxygen, like we said, if they're really having dyspnea, if all of a sudden they're very swollen, there's like really big differences, I would maybe consider it much more. But
yeah, I agree with you, Jen. I think, signs and symptoms of heart failure you want to be really attentive to, and those would be the situations where I'd think about an echo. Yeah, unexplained tachycardia, oxygen requirement.
But there's no
paroxysmal nocturnal dyspnea, all those sorts of things.
Also, there's no good, though. We are always looking for the paper. It says like, this is who we should be doing echoes on, and that no one's written that yet. Like, we need that publication.
Yeah, absolutely. Sure.
Yeah. So usually these patients get admitted acutely to the L&D floor, and you have no real idea of their volume status when they get there. And so I was wondering what your usual recommendation is for preload, number one. Number two, would you consider a full preload right before you do the sympathectomy, since it doesn't have a chance to get kind of absorbed, if you can do that in a short period of time right before you do the procedure?
Melissa, do you want to take this one as an anesthetic?
Yeah. So the data, current data suggests doing a co-load, which would not be bolusing prior to. It would be while you're doing the procedure to have the IV open to give that medication while you're doing it, because when they're having that vasodilation, that's when you're kind of wanting all of that fluid to be going in to help avoid hypotension. And there's some good data to say that you don't need to give a bolus like 500 or 1,000 before. So having that co-load during it. It depends on everything going on. I take a look at, like, obviously you don't want to overload them, but I take a look at what does their crit say, because, I guarantee they're not taking their iron every day. And then I'm looking at it and it's 40. Well, I know that they're very behind with that. And so I take a look at all of those things, and then I have my co-load, and I still do, I'm sure I do probably still 500 really. And then I really slow things down. And then I keep my blood pressure up, and then I start the phenylephrine drip as needed. But I really try to use my phenylephrine more than my fluids in those types of patients when I'm running into issues. And so that's how I manage it. But I wonder if other people...
Are there situations for all the panelists where you would not use a co-load in a patient with preeclampsia with severe features?
Yeah, truthfully, I still would use just a little bit. Like, if they're on oxygen and all those things, like, maybe I would kind of consider, but I feel like I need to at least get the phenylephrine in. And so I have to have something there, but I might really reduce it in that kind, and I really slow it down. But I feel like I don't want to, because if I start worrying about those things, then I'm going to end up with severe hypotension, and I don't want to deal with that. So it's kind of a real balance and a lot of vigilance.
I think one of the hardest patients to manage in all of obstetric anesthesia is the preeclamptic that has pulmonary edema and renal failure.
And those are the ones that forever ago we used to put Swan-Ganz catheters in. We don't do that anymore. And those were the people that I would echo, number one. And number two, I think those are the ones I'm really, really careful about fluid, giving too much fluid in. So, and even if it's just the high creatinine and not necessarily pulmonary edema yet, those are the ones I would be very judicious about fluid management with.
But it can be hard, I think, knowing whether oliguria is due to the preeclampsia and intrinsic renal dysfunction versus hypovolemia. I think echo can be really helpful in that context. Matthew.
Hi, everyone. Thank you for a great talk. My name is Matt Wilshire. I'm at Christiana Care in Delaware. Have any of you guys at your institutions utilized continuous blood pressure monitoring with the non-invasive finger cuff? And if so, how have you used that in your practice? Have it been helpful? Has it not been helpful? Just because we're getting pushed by our institution to kind of utilize like our Edwards and Clearsight more. So just want to get your guys' thoughts for these high-risk preeclamptic patients.
We use it quite a bit. I don't know if you guys do or
For a study, we studied
just for
we wanted to in a preeclamptic group. I was just doing a study. So in clinical practice, we don't have it at my institution, but we were looking at the differences in like the continuous blood pressure monitoring and just like the regular blood pressure. And so more to come on that, because that was one of the few RCTs that it was trying to figure it out, the variability in a group of preeclamptic women. That's
we use it quite a bit, a lot of times in our cardiac patients where we don't feel like they need an A-line for 3 days, but we would like to know what it's showing. I will tell you just practically just a couple of things. I think that it is very helpful to use because you would have it continuously like an arterial line, especially in something emergent, and you can throw it on. One of the challenges, a couple of like practically, is that it's really heavy and patients hate it. Like they really get upset about it. They get sweaty under there and they actually prefer an A-line. I've had patients just say, can you just put in the A-line, because they just don't, they get upset, and it is pretty weighty actually. The other problem is just for situational awareness is that the nurses have to physically chart. I don't know about your Epic, but mine, they have to physically go in and put what the pressure is because it's on a different system and it's not hooked into the blood pressure on the machine. And that becomes a challenge because then if they haven't sat down and entered those numbers, you have no idea what the pressure is until you go in the room. So I think that until those things are fixed, I think that it makes it a little bit hard to use. But I will tell you, we do use it, and I do think it's very helpful. And I have seen when we did do an A-line, it was very well correlating, and I thought it was really great.
Maybe show of hands in the audience, who's using this routinely in obstetrical patients?
Just the cardiac ones, just to be
Okay,
clear.
Hi, I'm Marie-Louise Meng, and I was with Melissa at Duke where we had it, which was phenomenal. So does everyone know what this technology is? So I think pretty soon, like how we think we need to have pulse ox on every patient, we're going to think, why haven't we been having continuous blood pressure monitoring this whole time now that it's available? So you're lucky that you have it. Most of us can't afford it. But they're hopefully making these that it's just blood pressure and not all the other parameters, and to make it less clunky, not have the thing on the hand, and that it can connect into any monitor. So I think the preeclamptic patient is the perfect patient that we should really be having this on, and the push to have it on laboring patients, not just the ones where we're standing there monitoring them in C-sections, is really going to pick up on the morbidity and prevent some of this morbidity. So, I mean, that's the future. That's what I think we should be pushing for these patients. Because I think we're missing a lot. And I think in a way it makes it easier because then you can have less staffing if you have more accurate stuff. And how many times do you get called for hypotension in a labor room and it's because the cuff was on the elbow or it was the wrong size cuff? Like that is not acceptable. Like in 80/40, that means nothing. When we have technology that exists that can give us better numbers non-invasively, I think that we should be making a push for this. Because you know who's pushing for it is the cardiologist in EP. They all have it. They all have it for TAVRs because it's smoother and easier. So I think it's great technology, and hopefully we are getting it at Vanderbilt, right?
And it also has SVR and cardiac output on the reading, which is really cool. So I'm just saying I think it's great.
Okay, we're almost at time. I think one more short question. Okay. All right. Well, thank you again to the panelists for your excellent talks.